السلام عليكم دكتورة هالة، مساء الخير.
عليكم السلام، مساء الخير.
مساء النور، كيف الحال؟ إن شاء الله بخير. شكرا جزيلا على استجابة الدعوة، شكرا جزيلا.
I'm honored to be here. Thank you very much for the gracious invitation.
Thank you very much. Okay, so if you allow us, we will start now. So, Assalamu alaikum. Good evening, dear colleagues and friends. Welcome to the last session of first day of 8 quick conference meetings. And we hope that you enjoy all the sessions. And today we are going to have the last session for in the Hall A. It will be a guest of honor for us to have Dr. Hala. She is the guest of honor for today in these sessions. Dr. Hala Al-Hilali, she's a professor of ophthalmology, Cairo University, Vice President of Egyptian Association Pediatric Ophthalmology and Strabismus, Advisory Board Member of International Pediatric Ophthalmology and Strabismus Council. She is also International Strabismus Association Board Member, co-chair of ISA Website Committee, Director of Pediatric Ophthalmology and Strabismus Unit, Cairo University, 2015-2019, Special Interest Pediatric and Adult Strabismus, Pediatric Cataract and Pediatric Glaucoma. And we are happy to have Dr. Hala with us today and to give us a guest of honor lectures or keynote lecture for us. Dr. Hala, the mic with you, please. You can share the screen. Can you stop share the screen, please?
I will. So share screen. Again, thank you very much for the gracious invitation. I'm really honored to be here presenting pediatric cataract surgery in 2023. I have no financial interest to disclose. The management of pediatric cataract depends on whether it is unilateral or bilateral, as well as the age of the patient. In unilateral cataract, if the patient is less than 6 months of age, we perform first Plicata or limbal lensectomy, followed by visual rehabilitation with contact lenses or aphakic glasses. Patching of the fellow eye is carried out to treat the deprivation of amblyopia. If the child has unilateral cataract but is above 6 months of age, bimanual irrigation aspiration and an IOL is implanted. Pars Plicata, posterior capsulectomy, anterior vitrectomy is performed, and then patching of the fellow eye is carried out again to treat the amblyopia. In bilateral cataract cases, if the child is less than 2 years of age, bilateral Pars Plicata lensectomy is performed, followed by aphakic correction with glasses or contact lenses. Between 2 and 6 years of age, phacoaspiration and IOL implantation is performed, followed by posterior capsulectomy and anterior vitrectomy. This can be either performed through a Pars Plicata approach or through an anterior approach via a posterior manual Capsulorhexis. If the child is 7 years or older, we perform the same procedure without anterior vitrectomy because the risk of epithelial cells proliferating across the anterior vitreous space is reduced at that age, and the child is old enough to be able to sit at the YAG machine. This is the consensus that we use in Cairo University Pediatric Ophthalmology and Strabismus. This is what we do in cases of unilateral and bilateral cataract patients. Of course, micro-incisional techniques have really helped a lot in pediatric cataract surgery, minimizing surgically induced trauma, decreasing the inflammatory response, hastening post-operative recovery, allowing us immediate optical correction and amblyopia treatment. I prefer in cataract surgery without IOL implantation to use the Pars Plicata approach for lensectomy because it results in minimal surgical trauma to the cornea and the iris, reducing the inflammatory response. It ensures that there is no corneal scarring related to incisions, no iris strands adherent to the corneal entry sites, and ensures the absence of vitreous in the anterior chamber or incarcerated at the incisions. You can see here the gonioscopic appearance of iris attached or incarcerated to the corneal incision. This is seen through a gonio prism. The sclerotomy site depends on the age of the patient, and it's related to the postnatal development of the ciliary body and the pars plana. So children up to the age of 6 months, in children up to the age of 6 months, the sclerotomy site is 1.5 millimeters from the limbus. But as the child gets older and the eye grows, at 3 years, the sclerotomy site is further back and it's placed 3 millimeters from the limbus. This is the regular case of pars plicata lensectomy. Conjunctival incisions are performed, mild or cauterization, followed by the creation of the incision with an MBR blade, and the incision is carried into the equator of the lens. The irrigation cannula and the vitreous cutter are introduced. The port of the vitreous cutter is placed to the side, and only aspiration mode is activated to remove, and that's all that is needed to remove the cortex. This is followed by directing the port of the vitreous cutter posteriorly to initiate the opening in the posterior capsule, and this is then enlarged to an adequate size. When we keep the port of the vitreous cutter to the side, this is to avoid premature opening of the anterior or posterior capsules until all the cortex has been removed. After performing an adequate posterior capsulectomy, the port is again directed anteriorly to remove the central part of the anterior capsule, and this is kept until the very end. This reduces turbulence in the anterior chamber and minimizes the risk of injury of the cornea or the iris. Anterior vitrectomy is then performed, and the sclerotomy sites are closed. The parameters that we use during pars plicata lensectomy are for cortical aspiration, a linear vacuum up to 400 millimeters mercury, keeping the cutting rate at a minimum because cutting is really not needed. Anterior and posterior capsulectomy require a linear vacuum up to 500 millimeters mercury and a cutting rate of 800 cuts per minute. Anterior vitrectomy, again, the cutting rate is kept high at 800 cuts per minute, but we reduce the linear vacuum to about 300 millimeters mercury because you don't want to be pulling excessively on the vitreous while you're performing the anterior vitrectomy. We oftentimes encounter persistent fetal vasculature cases with vascularized membranes. And if you look at this membrane, it looks like there are a lot of blood vessels on it, but most of these blood vessels are ghost vessels. There's very little bleeding that occurs from them, and there's no need to cauterize most of these membranes with vascularization. So after removing the lens cortex, an anterior capsulorhexis or capsular opening was performed. This is the retrolental membrane that's being removed now by cutting using the vitreous cutter, but you can see that these vessels are not bleeding. It's important here to enlarge both the anterior and the posterior capsular openings to a size a little bit larger than what we use for pars plicata lensectomy, because there's a very high tendency for these, especially for the posterior capsule, to contract in cases with persistent fetal vasculature. This is a rare case where where there was a ferocious blood vessels on the retrolental membrane. So after aspiration of the cortex with the vitreous cutter, endocauterization was introduced to occlude these blood vessels and reduce the incidence of bleeding as the vitreous cutter is used to remove the retrolental membrane. It was quite thick, required quite a bit of cutting with the vitreous cutter. This was followed by removal of the central part of the anterior capsule with the vitreous cutter. And I want to show you here an important step, which is shaving of the vitreous at the site of the sclerotomy to prevent incarceration of vitreous in the sclerotomy site, followed by closure of the sclerotomy. Oftentimes we encounter narrow pupils, especially with microphthalmic eyes. And in this case, 4 clear corneal incisions are performed. Viscoelastic is introduced into the chamber to inflate it. And I always take a good look at the angle of the anterior chamber. 4 iris hooks were then placed to dilate the pupil to an adequate size. This is really a case where a pars plicata approach comes in handy, because with the tenting up of the iris by the iris hooks, it would be very difficult to introduce instruments through the anterior chamber to perform a limbal lensectomy. After removal of the cataract, the sclerotomies are closed. The iris hooks are removed one at a time, and the 4 incisions are closed with, or are sutured with 10-0 embedded sutures. This is 2 weeks after the surgery. Patient came back for removal of sutures. There's a subconjunctival hemorrhage seen here from the injection of atropine subconjunctivally at the end of the procedure. The sutures are cut, and you can see here that there is minimal distortion of the pupil from the iris hooks that were used in the first surgery. Again, oftentimes we encounter cases with congenital absence of the central part of the posterior capsule, what we call posterior lenticonus. And the ultrasound by microscopy here shows that most of the lens matter has herniated through a posterior defect in the lens into the vitreous cavity. So in this case, again, pars plicata lensectomy comes in handy. The irrigation cannula is used to support the lens matter and bring it slightly forward to be easily aspirated with the port of the vitreous, through the port of the vitreous cutter. This will prevent any escape or of the cortex posteriorly. This is followed by activating a cutting in order to enlarge the already present defect in the posterior capsule, and then perform an anterior capsulectomy. And this is another case, but in this case, there was a defect in the anterior capsule. This is much rarer than posterior lenticonus. Again, a pars plicata approach was used. The sclerotomies were performed using the MVR blade. The irrigation cannula was introduced. Aspiration of cortex was carried out using the port of the vitreous cutter. And you can see here, as we remove the cortex, the outline of the central defect in the anterior capsule. This is followed by completing the cortical cleanup using the vitrectomy, the vitreous cutter, with again using only aspiration here. And this is followed by removal of the central part of the posterior capsule, thereby creating openings both in the anterior and the posterior capsule. This is a combined approach. Sometimes we need to use both an anterior and a posterior approach when we have what we call cataract plus, which is cataract beside other congenital abnormalities. In this case, there was congenital ectropion uvea, remnants of pupillary membrane, and an anterior polar cataract. And there was also iridocorneal adhesions at the periphery. So viscoelastic was used to perform a blunt dissection of the periphery of the anterior chamber, separating the back of the cornea from the iris. The blunt tip cannula of the viscoelastic was then used also to sever the posterior synechia that were present in all 4 quadrants, thereby enlarging the pupil. And then the remaining part of the surgery was carried out through the pars plicata in the usual manner. At Cairo University Pediatric Ophthalmology and Strabismus Unit, we studied the incidence and the risk factors for retinal detachment after pediatric cataract surgery. It was a retrospective review of cases that were operated between 2016 and 2019. 568 eyes of 372 children were included. Surgery was performed through an anterior approach in 66% of these cases, and a pars plicata approach in 34%. The incidence of retinal detachment was 8 eyes, or 1.4%. There was no statistically significant difference in the incidence of retinal detachment between eyes operated through an anterior or the pars plicata approach. The mean time after surgery for occurrence of retinal detachment was 2.14 years. Between the age of 2 and 6 years, an intraocular lens is implanted in conjunction with the cataract surgery. I'm sorry, this is not advancing. Let me see how that's going. So I don't know what to do. Okay. So I'll restart the program. I'm sorry. Can I share the screen again? I'm sorry.
Yes, please share.
Okay, thank you. I'll advance the slides. And I'll come back to where I want. I'm sorry about that. Okay, here we are. So 2 side port clear corneal incisions were performed, and the corneal tunnel was also carried out with the keratome. A bent tip needle was used to initiate the initial cut in the anterior capsule. This was followed by Capsulorhexis forceps performing the anterior Capsulorhexis using ripping rather than shearing. This is hydrodissection of the lens matter, followed by phacoaspiration, which really shortens the time that is taken in cortical cleanup. This is polishing of the back surface of the anterior capsule, followed by introduction of a single piece hydrophobic acrylic IOL into the bag. And once I ensure that the IOL is in the bag, the corneal incision is sutured with 10-0 sutures, and this is followed by introduction of a vitreous cutter through a sclerotomy in order to perform removal or the posterior capsulectomy, central posterior capsulectomy, and anterior vitrectomy. This is enlarged to an adequate size, followed by closure of the sclerotomy. I like the pars plicata approach because it ensures that the IOL is within the capsular bag before I remove the central part of the posterior capsule. It centers the posterior capsulectomy behind the IOL in a good fashion. It allows better sizing of the posterior capsulectomy, and it ensures absence of vitreous strands in the anterior chamber and the wound. Actually, presence of the IOL in the capsular bag stretches the posterior capsule, and it becomes easier to perform the posterior capsular opening and to size it the way you want. Sometimes the anterior capsulorhexis is difficult if there is difficult visualization of the anterior capsule. And in this case, an air bubble is introduced into the anterior chamber. Japan blue stain is then injected behind the air bubble in front of the anterior capsule. And then viscoelastic is used to remove the air bubble. And then the anterior capsulorhexis is performed. It's initiated again with a bent tip needle. And you can see here that the stain has really done a good job staining the anterior capsule, allowing or improving visualization. Again, here, ripping process is carried out in order to keep the anterior rhexis at a good size. This is a small capsule. Sometimes I perform a small capsulorhexis and then enlarge it later after introduction of the IOL. This is another case where the entire procedure was carried out through an anterior approach. After removing the cortex, a bent tip needle is used to create an incision, a small incision in the posterior capsule. Viscoelastic is then introduced behind the posterior capsule to push the anterior vitreous face back, and Capsulorhexis forceps are used to complete the posterior Capsulorhexis. Anterior vitrectomy is then performed through the anterior approach. viscoelastic is introduced to inflate the bag or the space between the anterior and posterior capsules. The IOL is then injected into the space between the anterior and posterior capsules, dialed in place. You can see here both the anterior and posterior capsulorhexis openings, and all incisions, of course, are closed or sutured in children. Another technique that you can use is to introduce the IOL after performing a rhexis, but leave the anterior vitrectomy till after the IOL in place. And this creates a barrier between the anterior and posterior compartments and reduces the possibility of herniation of vitreous into the anterior chamber. So this is a case where I did just that. Viscoelastic was introduced into the bag. The bent-tipped needle initiated the small hole in the posterior capsule. This is followed by a manual capsulorhexis, but you can see that in this case, there was a fibrotic plaque attached to remnants of the hyaloid, persistent hyaloid artery. The capsulorhexis was completed, but the fibrous plaque had to be severed with micro scissors. Viscoelastic was then introduced to create a space between the anterior and posterior capsules. The IOL was introduced in that space and dialed into place. After centration of the IOL, the vitreous cutter was introduced behind the lens to remove the fibrotic plate and also to perform an anterior vitrectomy. Cases where that are above the age of 7, again, we don't need to perform a posterior rhexis. In this case, viscoelastic is introduced into the bag. The posterior rhexis is performed. You can see here the viscoelastic pushing the anterior vitreous face back. The posterior rhexis is performed again manually with Capsulorhexis forceps. The IOL, once this is completed, the IOL is introduced into the bag here, or the space between the anterior and posterior capsules is dialed in place. You can see the posterior rhexis and the anterior rhexis openings. In this case, the anterior rhexis opening was quite small, and I enlarged it after I introduced the IOL. Then the corneal incision was sutured. Again, in Cairo University Pediatric Ophthalmology and Strabismus Unit, we carried a study, we performed a study of changes in intraocular pressure and anterior chamber angle after congenital cataract extraction. It was a retrospective observational study that included all congenital cataract cases with a minimum of 1 year postoperative follow-up. IOP and gonioscopy were measured at 1 year and 2 years. Actually, this study is still ongoing. Every year, we call back all the patients to measure the intraocular pressure and to perform gonioscopy. But this is part of the study that has been already published. 424 eyes were present in the database. 206 completed 1 year follow-up. Intraocular pressure was elevated in 23 of 201 eyes, 11% at 1 year follow-up, and at 11 of 86 eyes, or 13%, 2 year follow-up. Risk factors for elevation of intraocular pressure were age at surgery, if it was less than 2 months, aphakia or absence of an IOL, and increased central corneal thickness. Currently, we are using an enhanced monofocal intraocular lens in the pediatric cataracts for children 6 to 13 years of age, and we're comparing it to the standard monofocal IOL. So the enhanced monofocal IOL is optimized to improve intermediate vision without jeopardizing the distance vision, which is something that children really need now with the use of computer screens, and the intermediate distance is becoming very important. This IOL has a sustained shift in power, progressing from the periphery to the center. The aim of the study was to compare the visual performance of the standard monofocal IOL versus the enhanced monofocal IOL. It was a prospective randomized study in children aged 6 to 13 years with visually significant cataract, whether the cataract was unilateral or bilateral. 45 eyes were included in the study and were randomized. A thorough preoperative evaluation was carried out. Calculation of IOL power was done using the Barrett Universal 2 formula. Follow-up of the cases was done 1 day, 1 week, 3 weeks, 6 months, and 3 months after surgery. Now, we used monofocal defocus curves to study the performance of and to compare the performance between the two IOLs. And this is an objective method that measures the expected visual acuity at different simulated distances. It removes the factors affecting near vision, such as the near reflex, which occurs when viewing the near chart. It eliminates the learning effects of the chart. So what we do here is for example, by placing minus 1.5 diopter lenses in a spectacle frame, that would simulate the intermediate distance of 66 centimeters. And by placing minus 3 spectacle lenses, you will be simulating a distance of 33 centimeters, which is the near distance, versus the first one, which was the intermediate distance. So to perform the monocular defocus curves, any distant correction was placed in the trial frame. Distance visual acuity was measured at 4 meters using trial lenses from +1 to -4. Negative lenses were first added in 0.5 diopter increments until -4, and then positive lenses were added in 0.5 diopter increments till +1. Contrast sensitivity was measured using a Pelly-Robson contrast sensitivity-based chart. So when we looked at the defocus curves and compared the standard monofocal IOL, which is the orange line, versus the enhanced monofocal IOL, we found that the performance of the enhanced lens was much better at intermediate distance, where you see here at the -1.5 diopters, the visual acuity was 0.3 logmar, which is 612, reasonable intermediate vision without spectacles. Again, there was a statistically significant difference between the two, both at intermediate and at near distances. Contrast sensitivity was the same in both groups. So defocus curves showed that there was tolerance to residual refractive errors in the eye-hands group. Good performance with little affection of visual acuity was present in the eye-hands group with +0.5 and +1 defocus lenses, which meant that if we targeted a slightly myopic refraction, such as -0.5 or -1, that will not really significantly reduce the uncorrected distant visual acuity, but will have the added benefit of improving uncorrected intermediate and near visual acuity. The drawbacks, however, of this myopic target refraction is a theoretical risk of myopic progression in these children. Again, there was no difference in contrast sensitivity, which means that the enhanced monofocal IOL might have an advantage over multifocal IOLs, which usually cause a reduction in contrast sensitivity and visual quality. So finally, to conclude, to infinity and beyond, newer technologies and instrumentation has improved remarkably the surgical outcome in pediatric cataract surgery. Advances in intraocular lens materials and designs have ameliorated the performance of IOLs in children. And we expect that enhanced monofocal, extended depth of focus, and accommodating IOLs will hold promise in the future. I want to thank you for your kind invitation of having me in this prestigious meeting. And on behalf of Cairo University and Pediatric Ophthalmology and Strabismus Unit, I would like to welcome you all at the unit anytime that you would like to visit. Thank you.
Thank you very much, Dr. Hala, for this very interesting and comprehensive talk. There is many questions. It came to my mind myself. Maybe there is another colleagues they will ask. Now, in the first page, your presentation, you divided the cataract surgery, those they are unilateral or bilateral. I was seeing one of them that they are in the age of 6 years, but you are not implanting an IOL. I didn't get.
No, I am. No, I do implant IOLs, of course. No, I do implant. The first slide was unilateral cataract, and these were 6 months of age, not 6 years. So below
Yes.
the age of
The
6
second one.
months.
Yeah.
The second one was below the age of 2, where we don't usually implant.
Okay.
We
If you
can
are
start
doing-
implanting at 2.5. Yeah, but below
Why
the
you
age
are
of 2, we do.
implant- Yeah, this is
Sorry?
the question. Why below 2
Yeah.
years you didn't implant, while in above 6 months you can implant?
Because in
Unilateral.
exactly, that's a really good question. Thank you. In unilateral cataract, you really have to fight amblyopia, because this is a very, very severe type of deprivation amblyopia. And what you want to do in this patient is to get a clear, focused image on the retina of this patient at that age, at the age of 6 months, which is the age of critical visual development. This is why we can implant an IOL in a unilateral case above the age of 6 months. But in a bilateral case, you don't need to do that, because there is the deprivation amblyopia is not that bad. Both eyes have had cataract extraction, and you can visually rehabilitate them with spectacles, with glasses, until they reach the age of 2. Now, the reason why we prefer to do that is because of a myopic shift, a large myopic shift that occurs in the first 2 years of life. But that is something that you have to deal with later if you're doing a unilateral cataract case. And this is a compromise you have to go for.
Okay, there is another question, Dr. Now, what is the age that you feel that can you give the intraocular lens implantation, and you don't need to, to remove it after a while, because as the child is increasing by age, the size, the measures of the IOL calculation, it will be changed.
Yes, at the age of 7 years, when the child is 7 or above, we place the IOL power at the correct IOL power that we're getting, because there is little change, and there's little myopic shift after the age of 7 years. But below 7 years, if it is a bilateral case, we undercorrect and we leave a residual hypermetropia. We don't give the entire IOL power. We reduce that by 2 to 3 diopters to take into consideration the growth of the eye.
Okay, and then he will use glass spectacles to overcome the.
Exactly. Yes. Yes.
Anyway, it was a great approach. Also, I don't know what is the difference. You have mentioned about if you are approaching lens approach, a corneal approach in cataract surgery, pediatric, or you are doing in the pars plana or pars Plicata. So what is the difference between both this one?
Okay. Again, thank you. This is a very good question. I just wanted to show all the techniques that are possible to use. And they all, it depends on really the surgeon and what he prefers. So by placing the IOL into the bag before removing the posterior capsule, you really ensure that the IOL is in the bag. Because otherwise, sometimes the Posteriorhexis can extend. You might not be able to put the IOL in the bag. You would have to put it in the sulcus. But by placing the IOL first in the bag before removing the central part of the posterior capsule, you don't have that chance. You have the IOL in the bag. You go from behind, and as I said, the IOL flattens and stretches the posterior capsule for you, and it becomes easy and safe to remove the central part of the posterior capsule, knowing that the IOL will remain in the bag. That's one way of doing it. The other way of doing it is to perform a Posteriorhexis anterior vitrectomy and then place the IOL. Now that carries the risk of sometimes having the Posteriorhexis extend or becoming too large to place the IOL in the bag, and then you would have to change your approach and use a 3-piece IOL in the sulcus. And we always, in children, try to have the IOL in the bag because that reduces greatly and significantly the amount of post-operative inflammation.
Doctor, but whenever you start and implant the lens itself, then you go to do the posterior Capsulorhexis. Don't you feel maybe there is sometimes there will be an extended of or enlarged of the posterior Capsulorhexis, and then there is a chance of falling down of the lens?
Okay, so first of all, you use a very low flow from the irrigating cannula when you do that, because you don't want to increase the pressure in the anterior chamber and push the lens back. But when you do a controlled cutting rate and a controlled removal of the central part of the capsule, I haven't encountered that happening.
Okay. The last question, because I'm not a pediatric, or I don't have this.
Okay.
So whenever you do a cutter in the posterior capsule by the vitreous cutter, I don't know how you do it in this round circle very easily or without any, I mean, extended, or what is the technique you are using in this way? Yeah, I know you have to
Actually,
do it. Then, yeah.
Yeah, actually, when you use the 23 gauge vitreous cutters, they help a lot. They're much better than the 20 gauge. And just by practice and engaging the posterior capsule and just making sure that you're not pulling on the capsule as you cut it, that's how you do it.
I mean, it is a cut by cut, or you are just cut one area, then remove in a circle way while you are moving.
No, it's cut all around. And I don't pull on anything, and I don't try to do anything manually except using the cutter.
Thank you very much, Dr. Hala. This is for very interesting and topics that you cover today, and we are happy that you are today with us. Today I want just to announce that our conference, glad to have you with us, and to announce that also you have been selected to be the star of this conference, and we have it for you the trophy that it will be sent to you. I don't know if you can see it. Whenever it is.
Thank you very much. Really appreciate that. Thank you so much.
So thank you very much for your effort and for what you are doing in pediatric community for our children. Thank you very much, Dr. Hala, and we hope to see you, inshallah, also in the other session here tomorrow in a woman in ophthalmology.
Thank you.
Thank you very much.
Thank you very much.
And I would like to announce also for tomorrow for our colleagues. Tomorrow we'll start at 2 o'clock. And also the CME accreditation, it will be calculated according to the time or to the sessions you are attending. At the end, I would like to thank all dear colleagues and the friends, speakers for today, for after this all around 15 sessions that we done today, the whole of the day. Thank you and good night. Thank you. Bye-bye.